received apologies from Amar Guri, Ange Dempsey, Neil Barton and Mitten Ruparelia. I would like to officially introduce and welcome Graham Felston, who is our new audit chair, to the governing body. Welcome to the committee. I'd also like to welcome Will Pope from HealthWatch. Thank you for joining us, and to officially thank David Jones for all of his contributions in his term as HealthWatch chair, and we really value the input from HealthWatch to the committee, and very much look forward to continuing that close relationship. So thank you everybody for making HealthWatch so welcome. From a point of view of the on-call director, is anybody the on-call director this afternoon?
Jo, it's Ali. I'm on call today.
Okay, thank you. So if Ali has to disappear, it is for the purposes of being on call. Please do feel free to disappear if you need to do that. So what I'd like to do now is to move on to item 3 on the agenda. So looking at the minutes of the previous meeting, I'm going to go through this page by page for accuracy. And throughout this meeting, I'm going to use the page number on the pack rather than on the individual paper. So if we start with page 4, page 5, page 6, page 7, 8, page 9, 10, 11, 12, page 13, and finally page 14. Is everybody happy to confirm that that is a true and accurate representation of the meeting that took place last time? I'm seeing nodding, so those minutes are approved. Looking at the matters arising, I'm not aware of anything that is arising from that is not on the agenda this afternoon, and I'm delighted to see that the action log is green. So thank you everybody from that point of view. The next item on the agenda is the Chair and Chief Exec's report. Excuse me. And you'll have noted over recent meetings that is something that Toby and I have developed jointly in order to summarise the work that's taking place. Toby, is there anything you particularly want to draw our attention to?
Thanks, Jo. Thanks, Chair. Just to note that the report in the paper again this month is very brief and focuses on a few particular areas that aren't covered elsewhere through our agendas, either in the public or private parts of our meetings. But just for the record to say that both myself and the support team managerially across the organisation over the last month have been primarily focused on 4 main areas. Firstly, as we'd anticipate, continuing to respond and support the system operationally in relation to COVID response across the county. Secondly, linked to that, the vaccination rollout programme, which, as we'll hear later on from Sarah, is going tremendously well, and has been an enormous contribution on behalf of clinically managerially staff across the CCG as well. So that's been the kind of second huge area of focus over the last month. Thirdly, continuing to progress the really important 4 priority areas from the NHCP partnership in terms of those service and transformation areas. And then fourthly, and again something we'll touch on at points in today's meeting, the continued development of our system working in terms of integrated care system arrangements. Worth noting, Jo, that obviously last Thursday's national publications in terms of white paper and in terms of NHS England material and ICSs came out after our material was circulated and agendas were fixed for today's board meeting. But we'll touch on some of this under Ali's item around ICS a bit later, and I'm sure we'll want to come back to this in terms of development session for our March meeting. So just wanted to put that out there in case anyone was surprised not to see a fuller space on today's agenda for those areas. So that's very much where the exec and the management support side of the organisation, Jo, have been focused over the last month. Happy to take any questions or equally my director leads on elements that were covered in the paper, but I suspect many of these things, particularly what I verbally referenced, we'll come back to as we go through the agenda. Thank you.
Thank you. Any comments or questions? Thank you. So, and I think essentially, I think the other thing is to recognise how hard everybody is working across the system as well as within the CCG, that this is still an incredibly challenging time. And absolutely everybody across the whole health and care sector very much recognise how difficult it is, and very much value the general public for working closely with colleagues as well. So thank you to everybody who's been involved with everything that we're doing at the moment. Moving on to item 6, we do not have any questions from members of the public at this time, and we're really happy to receive those questions. Should people have any related to agenda items, we continue to be happy to receive those questions submitted in advance. The next item on the agenda is item 8, and that is the COVID update, initially the incident response. Lucy, thank you for the information in the pack. Is there anything else you particularly would like to draw our attention to?
I think the only thing obviously worth mentioning at this point in time is the fact that despite best efforts, we still struggle with some areas, the rates and the positivity. So people will have seen from the last report and updated reports since that are on Northamptonshire County Council website, there still is quite a big disparity between different areas in the county. And at this point in time, we're working very closely with Corby, with the local authority, with police, with environmental health officers in that lower tier authority to make sure that we get Corby's rates down so that they are comparable to or better than obviously the county average. And again, we've seen an increase in Kettering rates just recently, particularly in the 17 to 21-year-olds. So we're redoubling our efforts there. So generally good progress. Case rates are coming down at a county level, but we do still have some variability across the patch, and we want to make sure nobody's left behind.
Thank you. Any questions for Lucy? And I think the pack is particularly helpful, and for those of you who haven't seen it, that is obviously updated every Friday on the Northamptonshire County Council website, so it's something that you can become aware of obviously at any point. It is useful to be aware of what's going on within our county. I'm going to move on to the vaccination update. Sarah, this will obviously be a verbal report. The situation is changing quite rapidly. Over to you, Sarah.
Thanks, Jo. Just really a short verbal update in terms of progress on the programme within the county. Currently, the Northamptonshire programme has done over 165,000 vaccinations since starting. Offers made consistent with the government commitment to all of the top 4 cohorts as defined by JCVI now. Cohort penetration for all of the age cohorts in excess of 90%. And currently just working through the final piece around making sure that those who haven't been able to have their vaccination from those cohorts, those impacted by outbreaks, those impacted by illness, etc., can have that offer as quickly as possible as we start to just mop up cohorts 1 to 4. And then the big challenge, I think, or the big task next is working through planning for the rollout of cohorts 5 to 9. We have now started through the national booking service to offer vaccinations to cohorts 5 and 6, and an ask from a planning point of view to roll out the rest of the cohorts by the end of April in terms of cohorts 5 to 9. So very briefly, just that's the planning piece now for the programme to do over the next week or so in terms of what that rollout looks like for the next 2 to 3 months. I'll stop there, Jo. They're the headlines. Just happy to take any questions if colleagues have got any.
Thank you. Graham.
Yes, thanks. Thanks for the update. Much appreciated. We're hearing anecdotal tales of different areas now running at different paces, with some already down into 5, 6 and 7 invites. Last time we spoke, there was a restriction from the centre about sticking to 1 to 4 and supply concerns. So where are we on that in terms of sort of fair treatment across the country?
So cohorts 5 and 6 are now open. The National Booking Service has issued invitations for both cohorts 5 and 6, and our PCN model is also now offering to those cohorts as well. But I think it is fair to say that supply remains the constraint in terms of delivery currently, both within our county and others. But in terms of equity of offer, as I say, 5 and 6 are now open.
Thank you.
Any other questions? Toby.
Thanks, Joe. A couple of comments as much as questions. Firstly, I want to just put on record my thanks to all of CCG staff, clinically and managerially, who've been kind of contributing to this effort. It is something which has been an enormous sort of achievement to have reached where we've managed to get to this week over such a short period of time. And in particular, my thanks to our primary care network colleagues as well, and general practice across the county stepped up tremendously to this, in spite of all of the I think lumpiness and bumpiness was the Boris phrase in relation to vaccinations around, you know, supply and logistics and booking systems and all the rest of it, being really, really well supported as a county by our GP colleagues and primary care staff who've stepped into that space, as well as our hospital hubs and as well as NHFT in particular playing a big role with the vaccination centre. So firstly, just a big thank you and recognition where we've got to. I just wanted to echo Sarah's comments around kind of completion of the remaining cohorts. There is a concern for me as we move forwards that we focus understandably on rolling out some of the bigger numbers as we come down the age cohorts, but we know that there are still a number of people that we want to reach out to and certainly offer, if not have taken up that offer of vaccination in the kind of first priority cohorts. And in particular from a care home and from a housebound perspective, I've really had a big push this week on picking up with the team to make sure we're doing everything we can to reach out and make sure that that offer is there, and that in as many cases as possible that can be taken up. Looking forward though, just to touch on something Sarah referenced there about the kind of next phase of this. As we do start going down the population pyramid, the numbers become larger. It's just what the math does to this. And therefore the volume of capacity required, as well as the second dose element, once we get closer to that kind of 12-week period for those people who've already had their first vaccines, means that the volume that we require in terms of capacity across the county really steps up. And therefore, both from a workforce point of view and also potentially from an impact on other areas of routine general practice point of view, we need to do that in a really considered way. So I know, Sarah, that we've got yourself and Chris Pallow from the programme team joining us tomorrow at our Chief Exec System meeting in order to share both work on volume and capacity planning over the next period, and also for a conversation about how do we move the day-to-day management and running of this into something which is more sustainable over the next 6 months or so as we run through towards September. Because at the minute we've got a lot of people, including some of them I can see personally on this screen now, who've been lifted largely out of their day jobs to focus on this, and they've done a tremendous job of getting it up and running and mobilised. But this is going to be running now for, you know, at least the next 6 months or so, and we need to make sure we've got that running on almost more of a kind of clinical division footing in its own right, to enable particularly us from a commissioning group perspective to get back into some of the other really important things we need to do going forwards for the population as well. So I'll leave it there, Joe, and we'll come back more to what some of that might mean, I'm sure, in subsequent sessions, but particularly keen to free up some of our senior leadership back into other areas of work as well. Thank you.
And I think the other element of the workforce is obviously the huge effort by the volunteers within the county as well, and obviously making sure that they're supported moving forwards, because this is something we're going to be doing for a number of months, and absolutely their input has been hugely valuable. Will.
Yeah, thanks, Joe. And I make the capacity point that Toby has just made, so I won't reiterate that at all, but totally agree with everything that Toby has said there. However, could I just add my thanks to Toby's for everything that everybody has done, clinicians, managers, professionals, volunteers. It's been a huge effort, fantastically well done. And also I could report to you that the cohort 5 rollout has started, in the sense that it is now being experienced by patients, and what I've seen so far has worked really well. So there's been some very smooth texting from GP practices, very smooth website to click onto, very smooth choice of appointments going forward over the next couple of weeks, and very smooth response to choosing a date. So far, so good. Thank you very much to everybody.
Thank you. Thank you. Those words I'm sure will be much appreciated by everybody involved. Any other comments about vaccination? Because obviously that is the hot topic of the moment that everybody wants to talk about. That's fine. So moving on to another hot topic.
Sorry,
yes.
Sorry to leap back in. I just wanted to say, just your final thought just triggered from a public messaging point of view. If there is anybody out there who is watching this, who is in Northamptonshire, who is in those top 4 cohorts, the early part of our whole programme here, we rightly had the message that was, you know, we will contact you, don't reach out directly to services. In terms of how we kind of complete those remaining folk within those top cohorts that maybe we struggled to reach so far, if there's anyone watching this or anyone that's listening to this afterwards who knows they've got family or relatives or loved ones in the county that are in those top cohorts, please do encourage them to contact the national numbers, to contact the online booking system, or if it's more appropriate to contact your local GP practice, because we really do want to make sure that if there's anyone still remaining in those groups that we've managed to reach out to you at the same time as doing what Will describes, which is starting to work our way down the rest of the population cohorts. Sorry to have jumped in, Joe, but I just thought I'd take the opportunity, given I know this is a live recorded session.
Thank you, Toby. Well made. So we're going to move on to item 9 on the agenda, which is the integrated care system. Obviously, people will be aware from the media and from lots of other areas that this is now very much another hot topic of debate. Ali, obviously, you have submitted the paper and the submission pack as well, which is very important and very comprehensive, and I am absolutely certain people will have read that. Is there anything you would particularly like to draw our attention to?
Thank you, Chair. Just a reminder for the governing body that when we sat in December, we had a working draft in front of us. So this is the final submission to NHS England. And since that point, the regional team has now recommended Northamptonshire to move forward to the national executive team to move forward with ICS designation in April. So it's just a point of clarity from our last governing body discussion. And as Toby alluded to, we've had the white paper, which was published last week, which we haven't got within the papers, but I'll probably turn back to yourself and Toby to open up a discussion and set some policy context. Happy to take any questions in terms of the paperwork that's within the governing body papers. And just one last point from me, there is a delivery plan embedded within the papers, which was an ask from Region for us to provide more context. It's just for governing body site, and that the subcommittees of the Partnership Board will be owning the delivery of that plan.
Thank you. And I think it does give a sense of what we're starting to work towards, but obviously there's a lot more detail that will come from this moving forwards. Any questions about the paper or the submission and where we're up to at this point? Toby.
Yeah, thanks, Joe. And Joe, apologies. I think we might have some Microsoft Teams gremlins this afternoon on cameras as well. I know on my screen I can't see Ali at the moment, but I could a few moments ago. And someone's just messaged me to say that I seem to have dropped off camera as well. So if you're hearing my voice but can't see me on screen, I apologies for that. And it may be an issue that other people bump into today periodically. Just on, so that wasn't the comment I was going to make. So on the ICS piece, of course, you know, last week we've had nationally the publication now of the white paper. We've also had NHS England's response to the engagement exercise that was launched pre-Christmas, and those things have come through since the slide deck that was in our pack together was put together. I have to say, having taken the time now and the opportunity to read on more than one occasion each of those documents that came out last week, I think everything that we have in front of us set out here absolutely remains in line and consistent with the national policy direction. I think, if anything, the developments of the last week of a white paper, and also particularly the legislative underpinning around integrated care system status and what that will mean as we transition, subject to the passage of a bill later in the year through government, through Parliament, the transition from CCGs and the replacement with those statutory ICS bodies. I think for me, as a board, we need to take some time to actually think through that timeline, which is really, really compressed. If you look at kind of April 2022 and the extent to which, you know, a lot of us spent much of the last couple of years bringing CCGs together, and we probably had an 18-month run up to that in terms of creating, certainly for Northamptonshire, that single organisation for last April. the scale and the complexity of this is of a different order of magnitude to that task, and that's not to downplay what we did so successfully for April last year, but this is a different order of challenge again. Now, personally, I'm absolutely of the view that there's a set of very logical and coherent reasons for the changes that are working their way through, but it doesn't detract from the fact that in kind of 13, 14 months time, we're going to see some very significant shifts and move across the county, particularly for us as the clinical commissioning group part of the system. So really just a marker, I guess, Joe, to say what we've got in front of us is absolutely valid and current at this point in time. I think it's still the right direction here, but I think we need to take some time, probably I'd suggest in our March thinking time session, in order to, as a board, just spend some time working through particularly some of the practicalities of that kind of timeline over the next 12 months. I'm very conscious about how we support also our member practices and general practice, and also support our staff through that transition period, because rightly a number of them will be anxious about the kind of change process that will sit alongside this organisationally, and we need to do everything we can to support our good people through that process. Thanks, Joe.
Thank you. Philip.
On page 68 of the paper we've been sent, or on the numbering, it talks about finance development and sharing of performance data related to the ICS governance. Do we have reassurance from all of the provider organisations that they are fully committed to that process?
So I think I can answer part of that, and my finance colleagues may well wish to contribute as well. Obviously, we do have a system finance committee, which you'll be aware does include general practice as well within that. I think obviously that is very much our commitment as an organisation. We are maturing and aiming towards thriving. I'm not sure, Ali or Stuart, whether you want to come in on the response to that. Ali, do you want to start? Are you there, Ellie? Maybe. Are you there?
I am, but I was going to turn to Stuart. I think it's better.
Okay, absolutely. Stuart, do you want to start?
Yeah, thank you, Joe. Because Phil's raised a couple of points there. One, from the finance viewpoint, yeah, the system is sharing more data financially than it has in previous. Is there still teething problems? Yes, obviously, as we go through it, but without shadow of doubt, we are moving forward. We share more openly across all system partners, and we are developing the model for the first time, bottom up across the patch, and we're going through the process of challenging as we speak now, with all of us in the room challenging everybody. So it's not just the commissioner provider, the other providers are there challenging the other providers, so it's a much more open process across everybody. So it's not commissioner provider, it's provider questioning providers. On then information sharing, obviously we are going through that process. There are many examples of things that are going ahead at the moment, and we keep writing data sharing agreements, which will also help us going forward. So obviously there are rules and laws that we have to follow, that we have to jump through these hoops to make sure, but it is progressing. But I can definitely say it's progressing on both fronts.
Thank you, Stuart. I think that answers the question. Andrew.
Yeah, just pick up on a couple of things that Toby said. I think one of my concerns is putting myself in a position of a member of staff who is working remotely and seeing a lot of press around closure of CCGs, the worthwhile nature of CCGs going past, and is it wrong, and worrying about their role and their transition going forwards. Now, I know a lot of them are protected going forwards, but are we seeing a negative impact in terms of staff morale on the basis of all this press speculation at the moment?
Who wants to respond to that one? Toby?
Yeah, I'll start, and equally other director colleagues might want to comment from their own team's perspective. I mean, certainly I think two things sort of help in this, Andrew. The first, that we have the kind of national commitment and the national kind of promise in terms of continuity of employment for all CCG staff sub-board level, which is something that I've taken every opportunity over my weekly staff briefings over recent weeks to kind of emphasise and to seek to reassure staff. That doesn't mean that staff will carry on doing exactly the same thing they currently do, but that there is that continuity guarantee there. And it doesn't necessarily mean that they will be placed and positioned within that new single statutory body, but might be supporting provider collaboratives or the work that we do at place. But I think that helps in that space. I think the other important thing is we've talked really openly about this direction for quite a period of time across the county, and actually the work we've got in front of us today that we've shared is consistent with that. And certainly I did a staff briefing session on Wednesday last week, the day before the kind of national material came out, and again was just kind of trailing what we were expecting to see in that. I suppose the final thing to say, another director colleagues might want to comment on this, none of that of course though takes away from the fact that, you know, that you can't remove the potential for some people to be anxious through this. And also lots of us have had different experiences. You know, I was talking to one of my director colleagues this morning, and I was starting off a conversation talking about how the number of NHS organisational changes I've been through, in closing one body down and creating new bodies over the kind of last 15 or so years. And that other colleague was saying to me, well, actually, this was the first time that I've been through that, because they've always worked in parts of systems that haven't actually been through the kind of close down of one statutory body and the creation of a new one. And I'm sure that will be the case for many of our staff as well, notwithstanding the fact many will have been through multiple changes. So I think we have to do sort of redouble our efforts in terms of how we support people. I think communication is key, and listening to how people are feeling. The other group of staff that, you know, I will acknowledge on this call, that employment commitment applies from a board level down, and that does mean from a personal point of view, I'm very conscious of my role in supporting the exec directors across the organisation, because the job they all do is absolutely mission critical, and we need to make sure that we find a way to support people over the next kind of 12-14 months through all of this. So very conscious of it, Andrew, but I'm sure, you know, there are going to be a whole series of different reactions and emotions as people hear things. Key thing for me is communication. Thanks.
Thank you. Ali.
Thank you, Chair. Andrew, just to give you a bit of the live discussion and feedback within my leadership team, within my directorate, and I know my colleagues are doing the same thing. We're having very open, transparent conversations about it. So even though we're threading it through the staff briefing, that it's being clear that there is a place to have a discussion with your director and with your teams, and that we don't shy away from having those. And I think the other point that Toby made is that this is building on the ICS development submission and that direction as we move forward. And there are some really good enablers within it. It'll be a difficult journey. But there is a degree of excitement coming from I've got 6 or 7 of the leaders across the organisation, but as with any organisation, there will be a spectrum around this, and I think a spectrum of understanding. I don't know whether any colleagues want to come in, but that's just my personal experience over the last couple of weeks.
Any other comments on this area? And I think it is remarkable when one looks at the white paper that's in the public domain, how consistent our ICS submission is with that. So I think this is very much a natural continuation, bearing in mind obviously the concerns that everybody is very much aware of, that this is very much the direction of travel we were moving in anyway. So if there are no other further comments, I'm going to move on to item 10, which is the public health report. Lucy, what would you like to tell us?
Thank you, Jo. So there's a couple of things that I want to draw your attention to, and I know all of you will have read the document already, but just for the sake of anybody who might be watching in later, I just want to make sure that people, one, are aware that the Supporting Independence programme has continued throughout the pandemic. So this is the group of wellbeing advisors that we have in public health who usually do face-to-face work with people who have got mild to moderate frailty, but who have been providing online support in different ways, with exercise classes, with just engagement, still with sort of one-to-one telephone calls for support, both around people's physical health, but also their mental well-being over the last 11 months. So it's making sure that obviously all of our primary care and our public members know that that is still available and continues to go from strength to strength and very much has adapted due to the pandemic. So please do use that resource, and within our papers obviously we've provided you with the reference referral details. The second service I wanted to again to just reinforce that it continues is our smoking cessation service, and people will see from the report as well that we've had I suppose you could call it a really successful year, but obviously COVID has really highlighted the fact that lots of people would have been sort of predisposed to potentially more negative outcomes because of the fact that COVID is a respiratory virus, had they continued to be smokers. So we've seen an almost doubling in the number of referrals to the team in the last year as compared to 2019, and we've therefore set an average 175 quit dates every month for the last year, which is extraordinary. Really high success rate, and part of that is to do with the fact that we've reviewed the different support that can be provided. So you've got one-to-one support, you've got team support that is obviously continues to be remote, but you've also got different options around nicotine replacement therapies, and also e-cigarettes have now been available for a year and still continue to be the most popular smoking cessation support process. So please, again, we've made sure that people are aware of that service. Please do use it, and obviously continue to encourage people to give up smoking. COVID is going to be around for some time yet, and we need people to be as as resilient as possible to it. And lastly, the other programme that I wanted to make sure that people are aware of is we have been continuing with the Healthy Schools programme. So obviously recognising that schools have sort of played really the hokey cokey, haven't they? Pupils been in, then they've been out, then they've been back in again, and then there's a selection of pupils in, and obviously it's very, very challenging, not just for the pupils but for the staff as well. So the Healthy Schools team have provided a wellbeing and resilience workshop via Zoom, and we obviously are making sure that we've got more of those because the positive feedback has been absolutely superb. And it's making sure as well that support staff for schools, so the various educational psychology support, etc., people are aware of what's available and obviously can tap into that as well. Again, it's not just for pupils but for staff as well. This has been a challenging time for most of us. So if I stop there, but I'm happy to take any questions about any other elements of the report.
Any questions or comments from anyone? Philip.
A comment to say how impressed everybody has been by the work which the public health team have undertaken during this pandemic, and continuing to deliver services at the same time. And then a question for Lucy, if she's had time to think about it with how busy she's been. But in terms of developing the ICS, and in particular I'm thinking about the localities developing into provider organisations. We did have some discussions about a year ago around how public health would be involved within the locality boards and going forward as parts of their assessment of health needs. And I just wondered, Lucy, if you and your team had given any thought to the future and the future involvement in public health in that sort of work.
Happy to come back in, Jo. So yes, we have, Philip. As you say, it's quite difficult to shoehorn it in along with the BAU that I've just talked about and the COVID response. But my team broadly, and in fact the two shadow authorities where I've spoken to both the chief execs and also the shadow director of adult social services, are really excited about what could be the future form of Northamptonshire. So there's the sort of strategic changes that are starting to be outlined that Ali's already alluded to, that bring public health and adult social care much more specifically at this point in time in the white paper, in line with the health care agenda. So making sure that we're thinking much more holistically about the causes of ill health and also obviously the use of community assets, etc. So one, at a strategic level, I think the local authorities are very excited about that and definitely want to make sure that the ICS direction of travel is built into the way that the new authorities work. The second bit more operationally, as you say, within the teams, particularly the provider arm staff, they're really excited and have already started to work in some cases alongside providers and in some of the community hubs. Again, in the report, you will have seen that the wellbeing advisors have been working in the frailty unit in NGH. And again, we know that as and when business as usual returns and we can do more face-to-face work, now we've got a couple more smoking cessation advisors. You know, we do want them to be going back out and working much more closely with practices and PCNs. So again, as that sort of different levels of geography become apparent, I'm very, very happy for my staff to be out there embedded in the community and, you know, really contributing to what will be those much broader and holistic health and wellbeing hubs, you know, at a sort of a PCN and locality level. I'm not precious about where they work. They need to work where they're going to have the deepest reach into the community.
And I think that's a really helpful reminder, Lucy, about the wider determinants of health, that this is more than about healthcare. And actually, we need to be thinking holistically if we're going to really improve the health and well-being of the people of Northamptonshire. So I think it's really helpful to link those things together and to build on all the brilliant work that's happened with the JSNAs in order to make a difference. And I think the link with the previous paper with the ISIS is about delivering those things at place, which I think brings in Philip's comments as well. So thank you. Any other comments on the public health report? So I'm going to move on to item 11, which is the governing body assurance framework. Over to you, Stuart.
Thanks, Joe. I haven't got much to say. As you know, during this period, we agreed this would stay verbal and we would manage it through the corporate management team. And directors would highlight anything specific in their papers that come to governing body. And at this point, there's nothing that as a corporate management team you wanted to highlight specifically under this item, other than those things in the people's relevant papers. So I'll stop that point, Joe.
Thank you. So any other comments on that item? I think that this is a pragmatic approach to the situation we find ourselves in at the moment, and obviously as time moves on we'll approach things differently. Item number 12 is the review of the Constitution. Now this is an item for approval. Toby, did you want to come in on the conversation?
Yeah, sorry, Joe. I was just going to make a comment that there's a number of things that obviously we changed some of our arrangements, that being one of them because of the operational pressures of managing through the pandemic. I know we're all kind of anticipating the Prime Minister standing up next Monday talking to us kind of a roadmap out of this. I just think we need to kind of come back probably at our next formal meeting with a view on when some of those things start to get reinstated, because certainly, thankfully, we are seeing the kind of wave of the operational pressures having dropped back down. The vaccine programme is still very much significant, but I think we do need to start looking at how some of those other things get reinstated as we go before we go too much further into next financial year. So I just wanted to acknowledge that, because I think we are thankfully starting to move to a place where some of those other things need to be looked at again.
Thank you. So going to move on to item 12 now, which is the Constitution and Governance Handbook. I say this is an item for approval. Stuart, tell us what we need to know.
Thanks, Stuart. So this is it's been through all the relevant committees, and it's to update both the Constitution and the Governance Handbook. So in essence, you can see the changes that have been made in section 1.4 of the cover sheet and the table 1. So basically, it's to ratify the small amendments that happened in the Primary Care Committee, which was to remove copy CCG and CCGs, the plural. They were just only small amendments. Basically, so that's the only update. Other than that, is then to approve the NHS Constitution, approve the handbook, and note that they will be put on the website. And I'll take them as read and take any questions.
Graham.
Yes, thanks, Stuart. As a new reader, I did take the opportunity to read this from cover to cover, despite the fact that there weren't many changes. I thought it was completely solid and appropriate document, and I'm happy to support your recommendation to adopt it.
Thank you for your fresh eyes on that, Graham. Very much appreciated. Ali.
Thank you, Stuart. A couple of questions for me. Particularly in terms of reference for the Quality and Performance Committee, are we clear that they need to connect and align with the system committees? I know that that's referenced in the finance. It's just making sure that we do have that embedded within our terms of reference as we develop our partnership committees.
Stuart, do you want to comment on that?
Yes, I think that is relevant for all our committees, how they link into the system committees. So that is relevant. So I'll take that point away, because I was right. We do mention the finance. I'll just need to go back and check some of the other committees.
Yeah, absolutely key. I think that's very much in the context again of what we've been talking about. That is important. Philip.
Yeah, 2 items. Page 158. Brackley Medical Centre has moved and the address needs to be updated, please. And then round about page 212, where it talks about the lay members and the elected members, and I have to declare an interest there because I am elected, but there's nothing in there about remuneration and how that was going to be covered.
Which particular element of remuneration were you expecting to see within that? There's
I was expecting to see something on page 212.
Okay, Stuart, are you able to mention off the top of your head whether, or from your knowledge, whether there's mention of remuneration for other members? I don't think there's any.
No, remuneration isn't covered in this, but I'll note the Brackley address. So I will make sure the Brackley address is corrected if they've moved. But the actual remuneration is not written into the Constitution as per se, because otherwise every time you had a pay rise or anything, you would be changing it, if that's what you're after, Philip.
So I would note that we have a remuneration committee. It is a statutory committee that we're obliged to have, and matters of remuneration would normally go through that committee. Was it a question beyond that, Philip?
It's because the people involved are not employees and so don't get statutory changes to their salary. Neither they pegged to any national framework, and so I just wondered if it needed to go before the remuneration committee in some formal way. That was my only thoughts, and I do have to declare self-interest because I am an elected member.
I think that is an interesting question, and I think it's one that could certainly be considered by the remuneration committee, but I'd be grateful for other people's views as to whether that actually needs to be in the Constitution rather than an agenda item for the remuneration committee. Bev, do you have a view on that?
Yeah, I mean, I don't think you'd expect to see it in the Constitution. I mean, where for transparency it's recorded is in the annual reports. So, you know, there's reference to remuneration of senior management and lay members in there, say, for public transparency. But I think I'm with Stuart in terms of the Constitution. It's recognised that they're remunerated roles, but you wouldn't necessarily put the actual payments in there because they could change, you know, for all sorts of reasons, not necessarily pay awards, but additional responsibilities, additional time that's served. So you would be bringing the Constitution back perhaps more than you would want to. So I think so long as it's noted that they're remunerated and then it's actually fed through to the public through the transparency of the annual report.
Thank you, Bev. Toby.
Yeah, I was going to make a very similar comment to Bev's about not incorporating within Constitution. I suspect, I don't know, Philip, and possibly not to kind of open out further here on this call, but if there are different, if I call it different constituent groupings across this board have different remuneration arrangements for different roles, whether it's the lay roles, whether it's elected roles, some of the appointed roles, the executive roles and so on. If there are particular issues in relation to any of those that you or any of the other members of the board feel need to be picked up and addressed, either from a consistency or equity point of view, the rent through your kind of line management, if I can call it that, so through kind of chair and Joe and into Remcom, is the route those things could be picked up. So I just restating that, I suppose, Joe, as where would those sorts of things get handled and picked up if there were kind of questions or issues in relation to that. I think it's through that route rather than a constitutional route, but I don't know, but I suspect that the question being asked may well be there's something particular that either Philip or others want or feel needs to be kind of addressed as part of that. So there is a route to do that, but I think it's through that route and through Joe and through Remcom if there are things we need to address rather than the Constitution itself. I hope that helps.
Absolutely, and there will be a number of changes through a year that will happen within an organisation that are not within the Constitution. The Constitution is essentially what we use as an outline, and then there will be detailed discussions that are not constitutional issues, and I think this would be one of those. But more than happy to continue that conversation at any point, Philip, if you want to address that through the committees that we have. Stuart, do you have any other comments or anything else you would like to draw our attention to before we vote on this one?
No, thank you, Jo.
Okay, so Graham, this will be unfamiliar to you, but I'm sure you'll be more than capable of doing it. So essentially, what I've done is I've put item 12 within the chat. If people are happy to approve this item, if you could put the word approve, and then when we have reached a policy, then the item will be approved. And those who have smartwatches linked to Teams will find that their wrists have been buzzing a fair quantity. Thank you. So, okay, so thank you very much, everybody who has voted within the chat. So that item is approved. The next item is a Sarah item, and we're looking at aligning the regional and local responsibilities. And again, this is a paper for approval. Sarah, what would you like to tell us?
Thanks, Jo. So just some headlines to draw governing body's attention to. This paper really consistent with a number of the other conversations we've already been having today in terms of kind of ongoing integration, future models for delivery. But this one outlining the NHS EI and system proposal for a joint advisory group to shadow the arrangements for NHS EI specialised services commissioning in the first instance. So currently those services commissioned by the region from a specialised point of view are the initial focus. On that we expect probably to expand over the longer term into all services commissioned by the region. The paper you've got is consistent, I think, with the November paper from NHS EI and also the current white paper, and looks at the approach to joint commissioning and integration for those services. In terms of the proposal, the paper is asking the joint advisory group looking to drive engagement, a shadow operating model, governance discussions within the region over the next year in terms of what that model might look like from April 2022. And the paper asking for approval from the governing body in terms of setting up a Northamptonshire working group in terms of supporting the joint advisory group set up by the region, and also just in terms of noting both the content of the paper and the timescales involved. That's just a summary of what we've got. Happy to leave it there and take questions if anyone's got any, and also to invite Ali as kind of co-sponsor of the paper to comment if she'd like to before we open up wider.
Any comments, Ali?
Just one comment from me is that wherever we take this docking in effectively of the national and the regional discussion into our system, it will connect into the integrated care system programme as we develop it, so we'll make sure that they're all aligned.
Thank you. And in particular, a lot of those areas have already started to align, so particularly looking at community pharmacy, aligning with primary care networks. This is again very much the direction of travel as we progress to ICS. Any other questions or queries about this paper? Lucy.
I just request with my DPH hat on that obviously public health is heavily involved in this as well, because of the fact that if we think about the white paper, it does slightly confusingly actually talk about delegating some public health functions to NHS England, which almost seems contrary to what we're talking about. So it would just be good to make sure that it's a collective view on how this is best managed going forwards.
Thank you, that's helpful. Philip.
It probably means I need some clarification from Sarah, but I couldn't see specifically what clinical involvement would be built into the structure of this proposed organisation. And from previous experience of working in this area, I think it's really important that you have effective clinical challenge built into the system, either from the point of view of some academic experts, or as Lucy's mentioned, public health to sort of steer these investments, because when it was lost, there was an effective loss of control of the commissioning of these services for several years. So if there is some reorganisation, perhaps Sarah clarify for you how it's going to be built in, but I couldn't see it in the paper when I looked at it.
Do you want to comment, Sarah?
Yeah, happy to. I think just to be really clear at this point, Joe, that we're talking about a set of shadow arrangements here. We're not talking about a group making any active investment decisions over the next year. We're talking about a joint advisory shadow set of arrangements, just for absolute clarity. And also, I think Philip's point is well made in terms of clinical representation, which is why you'll see the group asks for the setup of a Northamptonshire working group to support the JAG proposal, and I would expect us to work through the representation of that group, which is what the paper suggests, and we'd need clinical representation on that group. So in terms of who are the Northamptonshire reps, both on the strategic working group that we want to set up locally and on the joint advisory committee, we need to work through that with a view to including the clinical voice and the clinical challenge that Philip outlines in that set of arrangements. So definitively, we haven't got to the point yet about who is where in these arrangements, but it's a direction of travel, and the point is well made and acknowledged.
And I think to build on that, I think the whole issue of clinical leadership and professional leadership in its widest sense is absolutely key as we go towards ICS. This is not just doctors and nurses, this is allied health professionals and other professionals as well, and making sure that at all levels within the system that appropriate input is sought. So I think it is a point that's important. I think it's one we're going to come back to many times over the next 14 months and beyond that as well. Toby.
Thanks, Joe. Yeah, a couple of thoughts for me. One I was going to make, but Sarah's just picked up on the kind of clarity around this is a transitional thing. So in effect, this is when CCGs were established, there were some functions that NHS England nationally and regionally held on to in terms of specialised commissioning. This is NHS England putting in place a way of local areas getting back round the table again where those decisions are being taken and being jointly involved in it, but at the moment that kind of budget responsibility is still sitting absolutely with NHS England. If you roll forwards and look at kind of white paper and last week's national ICS documents, roll forward to April 2022, and it's quite likely that those specialised commissioning budgets will sit within a local ICS place budget, in the way that actually if you roll back to primary care trusts, when there was a Northamptonshire primary care trust, those budgets sat within Northamptonshire. But what in effect this would do is give us the way over the next year to start to build that back up again at an East Midlands level, so that we've got the ability to still do those things at a larger geography. So in effect it's us coming on to something that sits regional at the moment. I suspect that will get placed down into local funding from next year onwards, subject to bills and the passage of that, but that I'd be very surprised, and this is largely about how we then get that scale back up again to a level which it makes sense to do it from a service point of view. And it is worth noting that there are some staff within the CCG, including some very senior staff, who have experience of how things like the East Midlands Specialised Commissioning Network used to operate, that we're keen to connect back into some of this area of work. So we do have some kind of memory of this set of commission kind of services. So I think this is a really helpful transitional thing. We're going to see more of this kind of stuff as we go through the year before we get to April 2022. So thanks, Joe.
Thank you. Andrew.
Yeah, that's really useful, Toby. I think I've just got a little bit of a suspicion around advisory groups in terms of where they think they have accountability or don't think they have accountability. And I guess that for me there's a sort of handover point of, have we got the confidence that when this transfers as a statutory responsibility that someone is going to be responsible for, that actually the mapping's in place? Because I can see when we're moving CCG stuff into an ICS, we've got a really good sense of history in terms of what's gone on and what needs to be mapped to where. This is less visible from my point of view. So does the advisory group have enough authority? And if they don't have enough authority, do the accountable people in that transition period have suitable sight of what the advisory group are going to be saying?
Toby, are you able to respond to that?
Yeah, I'm just going to come back with a view, but Sarah might equally or Ali wanted to chip into it. I think Andrew, well, not think, I know, because the conversations I've been directly involved with regional team on this at chief exec level, the intention here is to create something in transition in terms of where it then maps onto, that this actually becomes the thing it maps onto. So in a sense, you create something at a regional scale, which then with NHS England next year is likely to drop that sort of funding down into local areas. We would almost immediately at the same time be asked to can you upwards delegate? I think you can delegate it back into a regional arrangement, and this would then discharge that on behalf of however many ICSs we would then have across the region. So it's kind of creating something which has got a longer term life to it. I think the reason that it's advisory rather than decision making at the moment is because NHS England can't technically at the moment form something which hands that off into another forum. But I suspect what we'll find is that will in a kind of mesh governance kind of way, become increasingly actually that there are decisions that have been taken that have got the local systems around the table, even if technically the decision is taken by the NHS England people who are sat there because they're the people who hold that authority. Sorry, Sarah, you were perhaps going to respond. No,
I was going to say something very similar. I think the only thing I would just add is that's, Andrew, what makes our strategic group locally really important, because it will in essence hold the ring on who attends all of the work streams, sub work streams, etc. So we need to make really sure that we put the right people or groups of people into the conversations being had by JAG and the subgroups, so that we can both influence and take accountability through that mechanism, but also so that we regularly bring that back into the governing body space and make sure that we brief you as the governing body as to also what's happening in that space. So I think by construction of the right programme and by nomination of the right individuals or groups of individuals, we should be able to avoid the potential risk that you're outlining.
But I think it's worth raising those risks here, and this is absolutely appropriate to do that and to understand what the processes are. So thank you for raising those. Any other comments or queries on item 13? So looking at this paper, there are a number of items which I'm going to take together. We're asked to note the regional vision and proposals, to approve the development of the strategic group to oversee the agenda, collaborating appropriately to ensure engagement and delivery, and to approve the establishment of working groups and nominated representatives on the NHS EI groups, and note the challenging timescales for delivery. So the two elements to approve are the development of the group and the establishment of the working groups. I'm going to take those two items together. If you are happy to approve those items, I'm just going to pop item 13 in the chat. So if you are happy to approve that, could you please put the word approve in the chat? I believe we now have the required numbers. Thank you. So the next item on the agenda is one that needs to be ratified. So that's item 14, and that's the health and safety policy. This is yours, Stuart.
Thank you, Jo. I think you've summarised it. We just need to ratify this. It's been through the Audit and Risk Committee. There were some minor amendments. You can see amendments to that in Appendix 1 that have been done. We review the policies on a regular basis, so this isn't new, it's review. It's been through the Audit and Risk Committee, so here for ratification. Thank you.
Okay, so if you are happy, you can either put the word ratify or ratified. Both are acceptable within the chat. Toby, is there anything you want to comment at this point?
Sorry, Jo, I can't put anything in the chat. It won't let me put approve, ratify or anything on any of the items, so I'm not engaging. It's just it won't let me.
Okay, that may also be due to the Teams gremlin that has removed your face from my screen. So apologies for those who've been unable to do that. Toby, did you want to comment?
Yeah, so this might sound like a really pedantic comment to make, but can I just check and be really clear that the language wording we're asked here in terms of ratifying this as opposed to approving this? Stuart, help me understand. I'm sure there's a very specific reason I probably ought to know as the AO for the organisation, but why the language distinction between this and other things that have been through committees?
Because it got health and safety got delegated down in the process to the Ordinaries Committee. Therefore, it comes to the governing body for ratification.
Okay, so there is a distinction between this and other things that we're bringing from committees that we're then bringing through for approval. I just wanted to make sure that there was we were clear in terms of capturing the distinction between those things. Thank you, Stuart. I thought there would be an obvious explanation.
Thank you. That's helpful. And there may be others who had also not clocked why there was the distinction. So thank you for asking that question. Much appreciated. Do we have enough people who have voted? 1, 2, 3, 4. Yep, I think we have enough people. Thank you. So the next item that's on the agenda is item 15. This is definitely the Stuart show this afternoon, more than a minor speaking part. What would you like to particularly bring our attention to about the finance report?
Okay, thank you, Joe. So I will start with the trend continues as previously reported. This takes us up to month 9, December, at which point we were 2.8 million overspent officially as we closed the ledger, but we were waiting for what we have to claim the retrospective, which is the hospital discharge and the COVID vaccinations. What I can say is, since the time of closing the ledger, we have had up to month 9 of the hospital discharge reimbursed at 100% again to the CCG. So we are now just awaiting the vaccination costs and month 9 for the hospital discharge. So that takes us up to basically month 8 break-even position. Also, it's worth noting the trend continues, and this allows the CCG and the system to break even. There has been some national changes to do with the way the annual leave costs and accruals will be managed at year end. This does give the system an opportunity to do some stuff in year, and I'll close at that point. So take any questions.
Andrew.
Thank you. Thanks, Stuart. I just wanted to make a positive point in terms of the 100% reimbursement of COVID expenditure payments. There's an awful lot of hard work that went in behind the scenes, not just from the finance team, but also the primary care team, looking at each individual claim from practices and actually putting a really rigorous structure which has served well to the future. So I'd just like to thank the team for all the hard work and diligence applied to all those claims going forward.
Thank you. Absolutely recognise that, and thank you to everybody who's been involved with those. I know from a member practice point of view, they are very grateful to have had those expenses reimbursed, and thank those who have worked so quickly and rapidly to make those adaptations. Toby.
Thanks, Joe. 2 quick comments. First of them in the same sort of spirit as Andrew's, actually. Where we think we will probably end up this year in terms of forecast outturn position as a system, I think is not something which has been easily achieved. And I think, Stuart, there'll be a few other parts of the region that managed to land in a similar kind of place. That's not a kind of competitive comment, it's just reflecting the fact that I think our finance teams have worked well together to maximise the kind of opportunity and position across the county, which is a really good thing. So the first is a really positive piece, and thank you to you and your team and everyone else who often are actually in the kind of limelight in the midst of a kind of COVID and vaccination kind of year, but actually have done a really strong, diligent job for us kind of holding this together. So that needs acknowledging. The second point, I guess, is the slight flip side to that, and you probably know what I'm going to say, Stuart, which is the challenge looking forwards, given this is a paper about kind of financial context into next year, and the work that starts to be done across the system, looking at the underlying financial position, looks in a very different sort of position and place. And therefore, we're going to need to find some time as a governing body in order to work through our understanding of what some of that early stage modelling. There's still a whole series of assumptions and things fed into that, not least in terms of national policy, planning guidance, allocation positions, the different parts of the system. But at the moment, all other things being equal, the modelling work that's been done across the finance teams at the moment is both very open and transparent, which is a really good thing, but it's a very open, transparent exposition of a real challenge we've got going into next year. So just wanted to kind of put that down as a bit of a marker as well, because I think we're going to quite quickly in April, when we get and expect to get planning guidance, flip into quite a different discussion about the context for next year, and probably given the public sector financial context nationally, the next few years on this. But let's not detract from the opening bit of that, Joe, which was a positive thank you, like Andrew's, for the work the team have done to get us to that place. So thank you.
Thank you. Any other comments on the finance report? Okay, thank you. So thank you for that item. That one is for assurance, and obviously is a standing item, continues to be of interest, and very much expecting with planning guidance the situation may change as we move into next year. Going to move on to item 16, which is the contracting and procurement report. Sarah, what would you like to particularly draw our attention to?
Thanks, Jo. Just a couple of things, really. Again, this is a standing report. The first, which Stuart's already covered partially, but the current guidance will remain in place for Q1 of 21-22 from a contractual point of view. So the continuation of block contracts across the main providers within the health system. And then the planning round, obviously, to decide what happens then to the local contracts that replace that for the rest of 21-22. And then just to highlight, the paper covers it in some detail, but a significant amount of procurement activity in terms of both awards due to COVID and also the crossover between financial years. The paper been scrutinised in detail at Finance Committee, so I won't say any more than that other than to invite questions if colleagues have any.
Thank you. I'm going to take the liberty of asking a question myself. On page 486, there's a prioritisation matrix, and it's really just to note that there has been considerable work across the system looking at clinical priorities across organisations, looking very much at risk, and I'm aware that those two pieces of work are fairly independent at the moment. I'm really just to ask the question about hopefully aligning those areas so that when we look at clinical prioritisation and we look at the services, that we develop some alignment between those. So I suppose it's a hope and a comment rather than necessarily a question. And I didn't know if there was anything you wanted to respond to that too with Sarah.
Yeah, happy to pick that up, Jo. I think in terms of the prioritisation that's there currently, it's largely a prioritisation around contract expiry and what needs to be procured or relet when. I think I can assure you that the process that Procurement Delivery Group is now going to, which has clinical input, will mean that as those contracts come up by date, the clinical input into their re-procurement is definitely there. But I think it probably is really important from a clinical prioritisation point of view, as you say, that we perhaps try over the course of time to map the two together, because we may have things that aren't necessarily due for active procurement or change, which from a clinical prioritisation point of view, we might want to look at anyway. And we absolutely obviously have the ability to do that. So I'm happy to take something away into our next procurement delivery group just to understand what that mapping looks like. But to reassure that clinical input into the processes that sit behind that is absolutely there.
Thank you, that's really helpful. And the one particularly that draws my attention is the ophthalmology, which I think we've talked about as a clinical risk, and by procuring an appropriate service that actually reduces the clinical risk to our population. So I think this is not only to increase but also to reduce the risk to our population as well. Yes. Ali.
Thank you, Chair. I just wanted to give an update to the governing body on page 478, which is the residential short break section. So since the writing of the paper, NHFT have been awarded the contract, and you'll see from the paper that there were no preferred bidders from the initial stages. And this is a great example of, as we talk about integrated care systems, about how we work to resolve a problem collectively. So the Children's Trust, NHFT and the CCG recognised that this then was a risk potentially to families and those patients. So we've worked together to make sure that we have awarded that to NHFT, and their governing body and board have supported that, with the point that we will develop the service over the next six months to 12 months time to make sure that we don't stand still and we wrap around those individuals. So it's more of an acknowledgement of absolute system working to resolve. It's a small scale element, but if we can't resolve problems like this together as we move into an integrated care system, then we should be learning lessons from that. And I just wanted to make that point, and gratitude really to the Children's Trust and NHFT with the way that they worked with CCG.
Thank you. Important to note these changes for a very vulnerable section of our population. Thank you. Any other comments on the contracting and procurement report? Thank you. Thank you. It is interesting, and I think it is useful to see that level of detail around some of those contracts as well. So thank you. I'm going to move on to item 17, which is the Quality Safeguarding Performance Integrated Report, which is something we have long looked for as to how we combine all of these elements. I think, Alison, are you going to take us through this paper, perhaps supported by Ange, who would like to start?
So I think I'm going to start and then do a double act with Sarah, I believe, today. So thank you, Joe. Just to note that this report was presented to the CCG Integrated Quality Safeguarding Performance Committee in January. So just before I go into the report, I just wanted to note that we had quite a long discussion in that meeting in relation to some of the discussion we've had earlier today about how we feed into the system quality working. So we spent a lot of time looking at the report format and thinking about what that needed to be moving forward, so that we didn't duplicate effort across the system. So we're doing some work on that behind the scenes that we can report back on at future meetings. And we have our next system integrated quality performance committee next week, where we'll further those conversations. So I just wanted to note that today for governing body so that colleagues were aware of that. Just in terms of the report itself, I'll take the report as read. Just to give a couple of quick updates about points that were in the report. So the first one is in relation to our complaints team. So that was mentioned in your report earlier, Joe and Toby, in relation to the fact that our complaints team have now become embedded into the CCG. Just to note, we're doing some work in terms of how we expand their remit so that they become a wider patient experience team rather than just focusing on complaints. So I hope that will help some of our wider engagement work across the CCG as well. And then just the other point to note is in relation to St Matthew's Healthcare. So you'll note in the report that we talked about a follow-up risk review happening in February. Instead of the risk review, what we did was we had a meeting with NHS England and Improvement and the provider and other colleagues to discuss progress that they were making and to talk about the development of a quality improvement board for that provider in the same way that we have for St Andrews Healthcare. So our plan moving forward is that we will have a monthly quality improvement board with that provider, noting that obviously NHS England and Improvement are the lead commissioner for that service as it's a specialised commissioning area. And I suppose just also to note on that St Matthew's had an unannounced CQC inspection last Friday. And whilst we obviously haven't got the full report from that inspection yet, it's important to note that no immediate patient safety concerns were identified in that visit. So I just wanted to bring those things to people's attention today. Happy to take any other comments or questions, unless Sarah wants to do her bit first and then take questions at the end.
I think given that our desire is to fully integrate these issues together, I'm going to let Sarah do her element, because I think it is important that we take quality, performance and safety together. So over to you, Sarah.
Thanks, Joe. I don't, other than kind of reiterating the points that Alison's already made, obviously you've got an awful lot of information in terms of performance. I don't want to pull anything out from there specifically, because the picture is very similar as reported in previous months. I suppose the only thing I would probably mention is the work that is ongoing as part of both moving to ICS and integration in terms of system performance. What does a system performance and quality view look like? And both myself, Ali and Ange, in terms of input into that agenda, that work's ongoing, so it's just to highlight it, but there's nothing I want to pull out of the performance report specifically.
Thank you. So I'm just going to open this topic out for comments or questions. Anything anybody would like to mention or comment at this point? Philip.
Yes, it's about benchmarking of the report. I find it very difficult when I look at the report and see lots of red areas around scorecards to see what service our patients are getting compared with patients in the rest of the country. And I just wonder if it may be possible to do some benchmarking to see how we are performing compared with other healthcare systems, to give us, I think that gives a much better overall viewpoint on what's happening. And the second point I'd like to make, and I've made it repeatedly but not made it for the past year, is the continuing performance in A&E at the acute trusts. at a time when patient numbers have dropped, and you can see when we move out of the situation we're in at the moment, and A&E attendances will probably increase again. That, you know, what has been done to address the situation in the A&E departments to support them and improve delivery, if only measured by the 4-hour wait target. So 2 questions.
Thank you. If I could just take the liberty of commenting on the first question about benchmarking, I think it's really important we recognise that these are all individual patients with their own lives, and if everybody is in the region, it doesn't not performing, it doesn't mean that that person is getting the care that they need. So I think although it's interesting to look across the region, actually what's really important is to each and every citizen of Northamptonshire that they're getting the care that they need. And I think that's probably what matters to them. I think the benchmarking is interesting, but I think the care that we offer our patients is even more important from that point of view. From the point of view of your second comment, do you want to comment on that, Sarah?
I'm happy to, Joe, in terms of kind of very broadly comment. I think I would agree with your point around benchmarking. I'd also just add that from a timeliness point of view, benchmarking of other system data once it's validated is really, really difficult, and therefore providing, I'm not saying it's impossible to do, but providing a timely benchmark is quite challenging. Then from an A&E point of view, I think it would be fair to say that although we did see a dip in A&E numbers, that is on its way back up, and numbers going through A&E have substantially increased since the initial peak of COVID, so they are no longer continually reduced. In fact, they're more or less back at the level they were before COVID started. So just in terms of the premise of the question, I'm not quite sure, Philip, that I would agree with you that there are significantly reduced numbers going through A&E. The data tells us otherwise, and particularly in terms of social distancing and the ability of those departments to carry on operating as they were before. I therefore would recognise that A&E continues to be challenged, and therefore that performance for me wouldn't be unexpected. That doesn't mean it's adequate as you've described, Joe, but I don't think it can't be explained. I'm fairly comfortable that it can.
So the question is, what are we doing about it to improve the performance?
Toby, do you want to respond to that element before I bring anybody else into that?
Yeah, I mean, for me, this ties, Joe, in large part, Philip, to the conversation I think we've got coming up in our private part of the agenda around the ICAM work in terms of integrated care across Northampton, because the solution to this is how do we reduce presentations and attendances into our ED departments in terms of the pressure that then creates once it gets into the acute trust and their capacity, both from a space and a workforce and infection prevention control point of view, given how we're working in the minute. So I think for me, I'd be interested, Philip, to come back to that when we get into part 2 of this meeting today, because we're going to pick up on ICAM, which is heavily focused on how do we help to collectively reduce activity and presentation into our ED departments and ease flow through the acute trusts as well, all of which, all other things being equal, ought to help to improve performance in terms of the overall numbers as well. So Joe, I'd be quite keen for us to come back to that perhaps when we get into that bit a little bit later.
Thank you. And obviously the quality and performance are always going to be intimately linked in these areas. Julie.
Thank you, Joe, and just to support really what Toby was saying there about the ICAM programme, but also there's the 111 First programme that actually is now starting to be rolled out in quite a comprehensive way. So that means that anybody that's got a disposition for ED will get an appointment with ED, or they will then, if it's not quite emergency, then they will be given an appointment in some sort of same day clinic, hot clinic, etc. So that is actually what the hospitals are trying to do as well within their own departments, is to set up, for example, you know, somebody that might need a gynecological problem, rather than going through ED, then they should be going through a gynae hot clinic, and that's what we're working with both the acutes to make sure that actually people are put in the right place and they therefore don't go through the front door of ED. Just wanted to include that model of care as well, Joe.
Thank you, Julie. That's helpful, and I think joining up patients' care is what really matters to them. I think this is not just about metrics on a chart. It's actually really helpful for people. People don't want to go to A&E, and what we need to do is to make sure they've got the appropriate alternatives to A&E, and I'm very much looking forward to seeing that develop across the system. Any other comments on item 17, the quality, safeguarding and performance report? Okay, so we're going to move on to item 18, which is the primary care report. Julie, over to you.
Thank you, Jo. I will take the paper as read. Just a few things that I wanted to pull out from it, if I may. And as well as doing the COVID vaccines, and as well as people are doing those, which is absolutely amazing across the county for our population, GP practices have also been doing the flu vaccinations as well, and actually we've achieved over 80% of flu vaccinations for our population aged over 65, and that is the highest that it's 81%, and that is the highest that we have ever achieved for a long, well, at least for a long time. So I think we need to give that credit, as well as the fact that, you know, there was lots of activity, and not just the COVID. And then where the pulse oximeters are concerned, this is a really good news story. So we ordered 4,300, give or take, pulse oximeters, which were provided to us by NHS, and they have been rolled out now through general practice. So this is for remote monitoring of patients at home, which is a really, you know, a very good opportunity for us to be able to stop in face to face, but also being able to monitor people remotely at home. It's the first big programme that we have had in Northamptonshire around remote monitoring, and I think you all know I'm very keen on this kind of technology, which I think is going to be really good as we move forward. Also, the hospitals are offering pulse oximeters to patients on step down. So these are for patients with COVID who are over 65 and or have got suspected COVID, and their readmission rate is only 4%, which is quite incredible, really, from a respiratory point of view, for these patients who are leaving hospital. And also all our care homes, so all our residential care homes and our nursing homes also have pulse oximeters for their residents. So I just wanted to let governing body know that has happened over the last 2 to 3 weeks, and I would be pleased to give an update on some activity numbers at the next governing body. Thank you. And any questions that anybody have on the paper or what I've just said. Thank you.
Any questions? Not anything you ever wanted to know about primary care, but any questions about the paper or things that are happening at the moment? I think you've answered everybody's questions. Everybody's pleased, and as I say, thank you to all of our member practices and PCNs for everything that they're doing at these difficult times. And I know that we've had a lot of really positive comments from patients. I know our comms team have been promoting those, and I know that our population is grateful for what our practices are doing. Thank you. So I'm just going to sum up at this point the key messages that I've taken from this meeting. I think it's important that we recognise the impressive response not only to COVID but also progress with the COVID vaccination. I welcome the ICS successful submission and note the considerable consistency of direction with the published white paper. I note the approval of the Shadow Integrated Commissioning paper and the joint work with NHS England, and I welcome the remote monitoring and system initiatives to avoid prolonged hospital stays. So thank you, everybody. You have made time. What I'm going to do at this point is you can have 14 minutes. So if I could ask you to return at 3:10. Sorry, yep, 3:10. For those of you who are returning to the second the private part of the meeting. For those of you who are not, thank you very much for your time this afternoon. Sarah, you can switch off the recording.